Wonderful. Well, as people start to join, they can enter the webinar, but we might get things started and kick things off. So, good evening, everyone, and welcome to tonight's education session being run by Northwestern Melbourne Primary Health Network in partnership with our PHN colleagues across the state. My name's Hamish Blandon, and I'm part of the Primary Healthcare Improvement team here at Northwest Melbourne PHN. Tonight's session is Managing Respiratory Illness in General Practice, a really relevant and important topic at the moment, and we are lucky enough to have two fantastic speakers presenting for us tonight, Dr. Mukesh Haikwal and Carolyn Billington. I would firstly like to do an acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Bunurong people, and the Wathaurong people. I'd also like to extend this acknowledgement to those joining us from Indigenous lands across Victoria. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. On to a little bit of housekeeping now before we kick off. All the attendees today will be muted. If you would like to ask any questions, please do so via the Q&A box. There'll be time for some questions and answers at the end of the presentation. This session is being recorded. You'll receive a link to this recording and a copy of the slides in the post-session email. Questions will be asked anonymously as well to protect your privacy. So, as this is a webinar, please ensure that you've joined using the session, your name that you used for your event registration, or your phone number if you've dialed in. The PHN uses Zoom participants list to mark attendance and certificates, and CPD will not be issued if we cannot confirm your attendance. If you're not sure if your name matches, please send a chat to Northwest Melbourne PHN Education to identify yourself. As I said, we've got two fantastic presenters here today. We've got Dr. Mukesh Haikwal from North Altona Medical Group and Circuit Health, as well as Caroline Billington from Port Fairy Medical Clinic. Dr. Mukesh Haikwal is a general practitioner in Altona North since 1991, and co-founded the North Altona Health Hub and merged two local practices into the Altona North Medical Group. He also founded Circuit Health. During the COVID-19 pandemic, Dr. Haikwal drove transformative healthcare changes, including car park testing, video consultations, and deploying clinical health assistants and scribes. Circuit Health also led the Altona North Respiratory Clinic, Victoria's first federally funded GP-led COVID-19 screening and testing clinic. In 2018, he was awarded the Companion of the Order of Australia. He has held high offices locally and internationally, receiving numerous accolades throughout his career. So without further ado, I will hand over to Dr. Haikwal now. Mukesh, if you'd like to share your slides and take over.
Thank you very much. Well, good evening, everybody, and thank you very much for the invitation, Hamish, for asking me to talk about what's been a bit of a, I suppose something we've really enjoyed doing, and a great opportunity to make change, I guess, in the way in which we've done things. I'm not going to dwell on this. It's just me big noting myself. You've already done that for me, so thank you very much for recognising what has gone before. Nobody needs any reminder that we had major changes in the world, but certainly in Victoria in 2020 when we went into lockdown, and we had this thing called COVID-19 come through, and we actually didn't know what it was that we were participating in, what we did not, where we were going to be, how we were going to deal with our normal clinical load. And as you say, we had to find new ways of doing business, because if you're a practice with 2 or 3 rooms and you had somebody with COVID come through after you've had your 3rd room filled, and you've had to let the room air and whatever the rules were for cleaning, you'd be out of business pretty quickly. And so we moved to the ways of trying to do people by video, even though there was no video consultation at the time it started. We would see them as best we could with some minimal PP that we had in those days in the car park, and then look up. And we set up on the 1st of April 2020 to set the respiratory clinic going on our site. So I'm just going to give you some background on what's happened there, a bit of historical stuff. What actually happened is we refined the process every single day, because those of us, and that was all of us actually, were having to change what was done as the rules changed, as the Brett Sutton would stand up and say something, and we'd have to then adopt that as the day changed. And that kept going for 3 years, didn't it? It kept going through the COVID testing time. It went through the treating people with COVID, and it also went through the vaccinations. Things just kept changing. But the main thing that we learned through this process was about infection control, and about keeping people safe in our buildings, so that we could have business as usual happening and have some support for people who were needing care. So the picture in the background here is our back car park. You can just see the fencing on the back, which actually had 4 Nissan huts, 4 which are deportable cabinets, which were set up to be a portable cabins, set up to be respiratory clinic, where we would see people face to face. We would have 2 doctors using 4 rooms, and we would work, as I will show you, to do face-to-face consults. And those who were deemed to be able to be tested in the car, and we had that completely evaluated by the University of Melbourne, would drive onto our site and come through this tented area on the right-hand side and drive out, and were deemed to have the same level of care based on the triaging they'd had before they got there. So that's what things looked like in those days. These are the cabins I mentioned. There was a very strict protocol around cleaning and the way in which you went around. In fact, the way that they set it up by government and by Aspen, who were doing the original advising, was like Ebola but worse. And we had to make it more usable and agreeable, because the way that they set it was far too overcomplicated. And the key was you treat everybody like they got COVID, full stop, in those days, and of course any other respiratory illness as well. So, full PPE for everybody. Everybody who was swabbed the same way. Everyone was treated, was looked after the same way. Not trying to guess who did and didn't have the disease. So that's one of the things we had to do. When we greeted people, they would log in online through HotDoc. They'd come onto our system. We would then call them, and there would be a triage nurse who would do the triaging. When they came onto site, there was some testing that was done before they actually came to see us face to face or on the drive-through, including SpO2 and including temperature, and confirming what the triage had found. So anybody who was triaged to not do a face-to-face consult that was seen to be worse than they seemed to be on the phone, we would rechange their status and bring them through to a face-to-face consult. So it's a fairly spacey setup there. It was dry, which was nice, not heated, unfortunately. There was lighting, which was good, and we used this quite effectively. In the rooms were very bare. It meant that you could spray the rooms with bleach. It meant you could keep the surfaces clean, because remember at the beginning it was supposed to be droplet spread. We didn't. It was by touch. There was and blobs. They didn't understand about the aerosol. It took a long time for us to get the settings to change to, we've got to keep the masks on, we've got to keep in this case, face masks as well as shields and gloves and so on, because as we know now, it's aerosol spread. There's an iPad there, so we were dictating our notes by iPad to somebody on the other end, taking those notes, so that we didn't actually then have to write notes as well. And all the equipment sits on the table after that's used and is cleaned. We used the various cleaning agents. The Sonodet we all use for things like ultrasound cleaning and so on, but we couldn't use that all the time. The hand wipes from the Haliard's ISO wipes don't make your Welsh Allen handsets dissolve. So the Welsh Allen handsets there, we've got through probably a dozen of those in the time, because the Clinels, which we were using originally, would make that plastic dissolve. And the ISO wipes work well. They come out, and we still use those for that infection control. Also they're safe for the SpO2 machines, even for the kid-size ones there as well. So the method of transferring the collection of swabs was done in this great clear sequence, so that people were kept safe and it wasn't cross-contaminated with other collections, and people were kept safe by this process of bagging, and the person collecting that bag is not touching the tube, so they're deemed clean, whereas the person who's done the swab is deemed to be contaminated, and therefore will deglove before doing the next patient along the way. Cleaning the rooms, cleaning the chairs every time. That was a big thing all the way through the first few months as COVID, as you remember. And in fact, it actually continued all the way through. We continued doing this through vaccinations and so on, because it was part of the infection control we were rightly expected to adhere to as we went through this whole process. We then morphed our offering from the drive-through in the car park and the community of 4 demountables to bring it inside. So we fitted out a suite in our building, and that on the outside we actually had a carport built, which is waterproof, sort of. It does get wet under the ground, and when it rained a lot, we actually had to wear gumboots because it was actually a river out there as well. So you'd have every worst bit of weather you could imagine, from the heat of the summer to the wind to the rain. But we still would see people outside, because they preferred it if they could, because they didn't really want to cross and contaminate if they're inside. And even though the rooms were probably the safest you could get, with negative pressure airflow, HEPA filters, and all that the infection control cleaning I mentioned earlier. Along the way, we had the health assistants, who were a different workforce, a new workforce in many ways. They were made up of 100 or so different staff over the 30 months we ran this clinic. They included people who were students in health, so nursing students, paramedics. We had fully fledged paramedics, but we also had baristas, not actually barristers. Actually, I did have a barrister as a car park attendant. So we've had both baristas and barristers working for us, doing various bits and pieces, because they had no work, and they wanted to keep busy. But also, the young people actually needed work, and so they did a fantastic job in infection control. They helped us. They were not asked to do any clinical work, of course not. But we made sure that they were supported in everything that they did, and they supported us, so we could work more efficiently doing the doctoring and the nursing, whilst they did the infection control for us. This lady here is a trained travel agent, and she's now graduated as a nurse, having worked with us the whole 3 years plus, and is now fully fledged nurse, working at the Austin from early next year. Along the way, then we had 22 GPs work with us, 13 nurses, 63 of these health assistants and travel assistants. And they did many different roles. They didn't just do infection control. They scribed, they did the receptioning on the phone, so they didn't get bored, and they learned new skills, how to handle people, because people management, as we know, is so important. And many have actually come to work for us whilst they're still doing their student work in the general practice itself as well. So it worked extraordinarily well. And to what we did in those days was see 80. We built for 80 a day. At some stages, we went up to 120, 130 a day of people going through our system to have their respiratory care done. We had 20,218 unique patients. 470 suburbs. Of course, people came to Victoria. They did visit before they got locked in, locked down, or whatever. So we saw them from all sorts of places. Obviously, people had more than one consult with us. So there's under 35,000 people that came through. Of those, just over 12,000 were GP consults, face-to-face, and 22,000-ish were drive-throughs. Through the COVID positive pathway time, we did just over 1,300 positive COVID people, and we did 20,000 swabs. We also did innovative stuff with the Doherty, for instance. We did the swab testing using spit. We did the saliva testing for them, and it showed some benefit, not great benefits. And then, like every other GP in the country, and certainly Victoria, the vaccine story is one that we always speak of, but is often forgotten. General practice saved the community by doing the vaccinations, and it's really important to pat ourselves on the back, but remind people what important things that we did. This is the timeline. Really hard to picture how this went. From day one, we started on the 1st of April 2020. I'll always remember that. And how the various things happened along the way. There was various lockdowns, coming out of lockdowns after that first Christmas, the Queensland issue, and Sydney that first Christmas. Then we went through the next year, and we had the rugby and people getting locked down up to that. MCG being a problem, and then the vaccines came the following year, and then coming out of where we were to where we are now, which unfortunately is an awful lot of COVID still around. We had 18 cases in our clinic last week. Many people have seen this in nursing homes as well. So we then shut down the clinic in September last year now. Goodness me, it's a year. Hard to believe. It was quite traumatic because we got quite fond of the place, but also we felt we were doing good work. So where we are now is a very scaled down version of the respiratory clinic. We don't want to lose the knowledge that we gained from doing the respiratory, the GP respiratory clinic process. And we wanted to make sure that we continue to look after our patients, but in a way that was safe for them, but also safe for our other patients in the building, and also safe for them so they didn't get cross-contamination along the way. We continue to maintain that infection control. We still wear masks. In fact, in the respiratory clinic, we wear N95s, and people who come into the immediate care clinic have a respiratory illness, but they may not have a respiratory illness. It's also now an overflow clinic. It was set up to do other things other than respiratory, but we actually, in that whole year now, have had a complete full house pretty much every day with respiratory illnesses, because of course it's such a major part of what we do in our work. So as you approach our building on the outside, the drive-through centre outside there is still there, obviously, and that's where we park people. We'll still try and do the clinic consultations, but people who want to come into the building can come to the building as well and have their care there. We've created a triage script for the front desk so that if people ring in and have got respiratory illnesses, we can book them into the respiratory clinic. It means we can see them streamlined way, fully PPE'd, not wasting PPE, one doctor to the other, to the other, to the other, and making sure that there is a scheme of treating them, swamming them, following them up, and making sure that the doctor, the other providers in the service are actually safe. The patients are also safe in their own cars or in the building, and there's no chance or limited chance of any cross contamination in the way in which we do that. As we all know, you ask people a question, they won't necessarily be honest about the answers, but we can do the best we can to minimize that. And of course, it's not only COVID that's the issue here. We know that influenza is pretty nasty. We all remember, well, most of us will probably remember swine flu. I remember 3 of my doctors went out to the local nursing homes and literally crawled back into the door to be given the Tamiflu and driven home because they were so sick with their influenza. And this is what we haven't forgotten. This is again a chart. No point going through the details. How we would do the bookings, how we allocate them to come to the normal clinic, to the acute side of things, or go to the ICC. We would walk people through and check them on arrival, make sure that the appointment is as we think that it should be, and then what we do after the appointment. With electronic prescriptions, it means it's quite easy. We have an on-site pharmacy who will provide them pharmacy products if necessary. We still send them a WhatsApp, even though it's not legal, because we give them the prescription at the end, so they actually have a proper written prescription. But based on the WhatsApp prescription, they'll take the payment and dispense to the patient, and we make good the prescription after the consult's gone. So there's many things we've learned and benefited from through that COVID process that still works now. Still, it's important to have the usual equipment. Nothing new here, apart from the fact we actually insist on N95s in our clinic still. Obviously, there's not an awful lot being provided. I know the poor old PHN got fingered during COVID for not providing. The PHN isn't providing any masks. They were told that, and I had this from the health minister in 7:30 in the morning, in a very loud way, that was what was happening. And I had to tell him, you're not being given the truth, Minister. They haven't the capacity to do this. They haven't been given any supply. It took a long time for that PHN to get their masks, to be able to give them out. Anyway, so we actually do private billing now. So as a GP respiratory clinic, it was all funded by the Commonwealth. So you could say there's a proper fee set for doing GP work that was set by the Commonwealth. We now will charge in a normal way. We're a mixed billing practice. We have an FFOS machine which people can tap, so you don't have infection problems with the card along the way. And we have a very clear scheme of how you set up. We make a process of getting gowned up, because we have special gowns that we've had made. Some people still wear the face masks or goggles and doing the consultations. Some people will prefer a scribe, others won't want a scribe, but we make allowance for that. It's always been on our own software. One of the things that we refuse to do is use the makeshift rubbish software that's provided by Commonwealth. It was not fit for purpose. It made our processes much worse. This way, you do things the normal way. You want to do a swab, you provide a form, you provide a sticky from the form onto the swab, you put that onto the bottle, and it gets used in the usual way. So currently our staffing is much less. There's one GP working half a session a day, and we have a nurse and a paramedic or student nurse as an assistant. They greet the patients, they do basic obs, they support the doctor, they give stuff to them along the way, and you make sure that they get good information as they leave. We have undercover parking, which is useful with lighting. As I say, when it, like just now, it's raining cats and dogs, is the river underneath there, but we have gumboots, so we have the equipment, we have the technology to deal with the water. The consulting rooms are inside, are like they were in the huts. They're vinyl on the floor, vinyl on the walls, negative pressure into the rooms, and we've got HEPA filters as well. Again, minimizing contact, minimizing infection. And this is our workstations currently. So we've really hived down to a much smaller footprint. And this is what I would say is where we are when the ICC is not running. We have an ambulance bay, and in the foyer, we've put the clinical waste bin. The jug is what we call the health assistant. You put a plastic bag in there to collect your specimen. You get everything ready. You get all gowned up. You go and collect your specimen. You put it in the jug. Then you doff off, and then you do everything else afterwards. It takes 30 or so minutes to do that, to get your stuff together, to go and do the consult and the swab. come back, doff, off, clean your equipment, and then do your stuff. By doing it the other way, it takes 10 minutes. So when things are streamlined, you can do things so much better, and it's less of a drag. And actually working with other people in general practice was quite a new thing in 1990, and it made our life a lot easier. And we certainly enjoy working with these folks. We've learned a lot of things from the past. We didn't want to forget that whole infection control thing that we'd managed to make the best of along the way. We still want to make sure people are safe. As I said, we've had so much COVID last week. It beggars belief. Nobody's sharing about it in the community at the moment. Mitigate risks to people like myself that are not well, to people who are outside, our frail patients, of course, and using resources. You don't want to keep changing and losing N95s. We all know the cost, and you can keep the N95s, just change your gloves. And you don't want to have lots of people running around doing things like chooks without heads. You just want to do it in a streamlined way. So we still offer face-to-face consultations. We still offer telehealth, but we also offer the car park consultations, and that makes the whole thing very suitable for patients and the way in which they work. And it makes things more useful for patients to know they're getting the care in the right way, at the right place, at the right time. Sorry about that. That was a canter through, but I thought I better shut up. Thank you.
Fantastic. Thanks so much, Mukesh. An excellent presentation. What I'll ask, if anyone has got any questions, as we said, please put them through the Q&A function at the bottom of your screen. And what we can do is just at the end of our next presentation, we can have a bit of a Q&A discussion. So please feel free to use this time to put any questions down there into the Q&A, and we'll get to them just at the end of the presentation. I would now like to welcome Caroline Billington. So Caroline currently works as the practice manager at the Port Fairy Medical Clinic. She also works as a registered nurse and feeding consultant at the clinic. The COVID-19 pandemic saw Port Fairy Medical Clinic pivot quickly to ensure that the large nursing home and elderly community of Port Fairy were forefront of their business decisions, with some of these strategies still being in place today. Caroline's wish is that every patient receives a positive and inclusive experience every time they enter any of the 3 Port Fairy Medical Clinic locations. So Caroline, if you are there, please feel free to share your screen and kick things off. You might be having a few technical difficulties there with Caroline. I will give her a couple of minutes, perhaps just sorting out some IT problems there. But what we can do is still feel free to put any questions into the Q&A box, but I'll also just use this opportunity to go through and give a little bit of a plug to Health Pathways. So some of you may be very familiar with Health Pathways, others perhaps not. So what I'll do is I'll just give everyone a bit of an overview of Health Pathways, which is a really useful tool that's available to us. So, look, Health Pathways Melbourne is designed and written for use during primary care consultation. Provides clinicians with a single website to access clinical and referral pathways and resources at the point of care. This here is the homepage with the alerts, latest news, new or recent pathway updates, and links to useful resources and websites. The process for developing content for health pathways is a collaborative effort between our local GPs, specialists, allied health providers, and other subject matter experts. And each pathway is evidence-informed, but also reflects local reality. To access health pathways, just go to melbourne.healthpathways.org.au, then log in with your username and password. If you don't have a username and password, go to the site and register for access. You can also request automatic login for your practice, so you and all your practice staff don't have to keep logging in the username and password each time. As you can see, there are a lot of relevant pages for respiratory illness, as well as for COVID-19. Here we have the key pages: assessing respiratory presentation in general practice, and we also have COVID-19 practice management and infection control. So, very quick overview of Health Pathways Melbourne there for you. So I really encourage anyone that's not already using the site to do check it out, because it is an excellent resource that is free and available. I'm just going to see now whether Caroline's had any improvements for her video and audio capabilities.
I believe she said she's struggling to share her slides, but if you can share them, I think she should be able to speak. Carolyn, can you speak, so see if we can hear you?
I'm not picking up anything there either, unfortunately.
No, neither.
Whilst we work with Caroline, again, I just encourage to put any questions for Dr. Heikwall into the Q&A function at the bottom there. As we continue to wait, and our fantastic tech support team here sees if we can get Caroline up and running, I'd just like to give, I guess, a little bit more housekeeping on the session. So there's a QR code here. Please feel free to scan that with your smartphone and just fill out a quick survey for some feedback. You will also receive a post-session email within about a week, which will include the slides and any resources that we've discussed during this session. Your attendance certificate will be received within 4 to 6 weeks, and the RACGP CPD hours will be uploaded within 30 days. To attend further education sessions by us, you can go to this link here. And we also will have the recording of the session posted online at this link. So if you joined a little late, would like to rewatch, or if you have any colleagues that you think might benefit, I encourage you to check out that recording as well. And I'll come back one more time, Caroline, just to see if you've had any more success there. As we said, I'm happy to share your slides if we can at least get some audio from you.
She's going to try on her phone as well, connecting on her phone.
Fantastic. Well, whilst we get Caroline joining, perhaps now's a good time for a quick intermission. If anyone needs to get a glass of water, go to the bathroom, please take this opportunity, and we'll check back in with everyone just in a couple of minutes. Thank you. Whilst we're waiting, Dr. Hikewall, if you're still there and listening to us, I'm just wondering whether you perhaps have any other comments now that the floor is yours. Again, perhaps any advice for practices who are looking to perhaps implement some infection control measures at their practice at all? Sorry to put you on the spot there.
Yeah, look, thank you. It's very reasonable. I have been working with the State Health Department General Practice branch throughout the pandemic, and they're working very closely with the GP respiratory clinic piece and the transition to vaccines. And now the GP respiratory clinics done by the state we supported that process. And we've been working to say, what is it we can do to support people to do the respiratory work, and how do we get back to normal practice? So this happened throughout that, the last year or so, I guess, throughout 2022, because people still had GPRC, respiratory clinics to send to. We were finding a lot of people were coming back to us who we'd seen a few days, 2 or 3 days earlier, cleared of having any respiratory illness, because our swab testing would be not just for COVID, but for other respiratory illnesses. And they would go back to the normal practice. And we would always send a secure message link using HealthLink with a letter. So everyone knew what happened in our practice 24 hours after the test result came back. And so what we were finding is a lot of people still were coming back. And we would ring the practice and say, look, you actually need to look after these folks because they're getting quite toey about not being able to see you folks. And we haven't got capacity to take on all the patients that you normally see. That was not our role, and certainly not the intention. We want to support our colleagues in their home base. And so this conversation nobody's had this conversation with, well, so how can we do that? And so to me, it was very timely for you to say, can we talk about it? And certainly I know that the state is worried because I said COVID's not gone away, and flu's never been away. We saw an awful lot of RSV. As we know, when we as adults get these things, it can be quite horrible. Even the common cold can be pretty nasty. It's good to know. And so the way that we morphed, I guess, from the 120 max, the day it was heady days to, we'll see 15 or 18 now. We'll see them in 10-minute slots. We will have the infection control ready, as I said, with the staff there, because we don't use the rooms for the consults often. The infection control in the rooms isn't that we don't need to keep wiping everything down. But if we do use the rooms, we do wipe down. And at the end of the day, we do spray those rooms down as well. So we do maintain that level of infection control that we started with in those days now. And we still maintain our N95s, we still maintain goggles, and we actually have surgical type gowns so that we keep, and scrubs, so that we actually change out of that when we finish, just to make sure that we feel it's a different thing that we're doing out there. And because we're doing it with these health assistants in this case, we're quite efficient at doing it. And most of the doctors actually enjoy working with the health assistants and being more more time efficient. Caroline, you were coming on.
Yes, I am. Sorry.
That's good.
Might be fantastic timing
Look
from you
forward-
there, Mikesh and Carolyn. Caroline, thank you for joining us. I think we've all experienced these tech troubles before, so we can all appreciate what you're going through and what can happen from time to time. So thank you for joining us.
My apologies. I'm in Adelaide at a conference as well, so it's all a bit full on.
It's the joys of this hybrid and online work that we all do at the moment, isn't it?
Yes, it is.
Would you like me to share your slides
Yes,
for
please.
you? No problem at all. And look, what we can do as I'm going through them, please just let me know.
Yeah, I'll just say next slide.
When we can filter through.
Okay.
Fantastic. Well, Carolyn, over to you. Please take it away.
So thank you very much to WPHN for this opportunity. This is one of my clinics in beautiful Port Fairy. I would love to say that's what the sky looks like all the time, but it's not. We're a surf coast town in southwest Victoria. And at the time that COVID hit, we were it. We were the only clinic in our region. So if we go to the next slide, you'll see what our region looks like. So that first map is the 3 towns that we have clinics in. So we have Macarthur, which is, I'll go through which each of them are. We have Macarthur, Koroit and Port Fairy. But on the next one, you can see our outreach. We have patients literally from Mount Gambier right through to Hamilton and a bit further out, even some from Horsham and across to Warrnambool. And Warrnambool is quite a large town that has a tertiary centre, but they also have 9 medical clinics, of which I think there is only one that has books open to new patients. And both Port Fairy, Koroit and Warrnambool are all very big growing districts of young families and whatnot. So it was certainly an interesting time to be a single clinic in a large area during COVID. So in the next slide, so Port Fairy has a population of 3,340, which grows by about 10,000 over the summer holidays. And as you can see, that's our clinic. Now, that car park area is actually, that building right behind it is the 100-bed nursing home. So there's that and another area that we service and a 12-bed rural hospital as well. We have general physicians, dietitians, alcohol and drug rehab counsellors who visit us regularly to help us with servicing all 3 of our towns. The next slide shows Koroit, which is our other little town. It's got a population of 2,055, but it's growing a lot with young families. 2 primary schools, a kindergarten. Now at this clinic, the top photo shows that's our clinic. Those 2 rooms, and you can see a room further up the back, are our 3 consult rooms. So it's very cosy. And this is our car park out the side, which will become a bit more relevant in a minute. That area is where we used during COVID if we needed to for patients, because we needed to. We actually had to put up a screen along because the kindergarten is right next door. So it's all nice and cosy. And then the next screen shows our Macarthur clinic. Macarthur is a beautiful rural farming town. It's a very elderly population, but Macarthur is run by Southwest Healthcare, as you can see. So we had a lot of interesting times during COVID because we had to go by Southwest Healthcare's rules. So we were just the doctor that went up there. So there was a lot of interesting conversations about what Southwest Healthcare wanted us to do from a hospital perspective compared to what we needed to do to actually help the town and the people within it. So on the next slide, we go through the considerations we had to do during COVID. So our communication to staff and the community of the new changes. So we literally turned around our telehealth within 4 hours. Our doctors asked if we could do it, and I have an amazing reception team. Once again, Macarthur was a bit different because a lot of that town, while there's a lot of young people, there's a lot that don't have social media. So getting that story out to them of this is what we have to do was really quite difficult. Thankfully, the district nurses are in Macarthur, so therefore they helped us a lot with the communication to them. Whereas for Port Fairy and Koroit, we were able to turn it around quite quickly. Communicating to the community on the regular basis was via our social media and websites, but also Port Fairy is a wonderful little town, as is Koroit, that word of mouth gets around everywhere quite quickly. Our main aim was to protect our nursing home, hospital and the vulnerable community. So of our 8,500 patients, about 3,000 of those are over the age of 65. So we really focused on making sure that we were on top of everything so that we could help that population of people. Education to staff and the management of changes. We are literally next door to a public hospital, so we had to also go by their rules, and especially with the nursing home. So there was lots of state versus federal, which was always fun, which I'm sure a lot of people have had to deal with. We had very, very minimal support from the respiratory centre. So at the start of COVID, we were the only clinic. 12 months in, there was another clinic that opened up. So we did have the availability of a drive-through area, but we tried to get everybody to go to the respiratory clinics. There was a lot of toing and froing with those respiratory clinics. People were waiting, like in a lot of places, for 2 hours. They wouldn't go over there. Some of them couldn't get over there. So we really had to look at how did we look after this cohort of people, because as you saw, our backyard is pretty shut in. So we can't have a lot of people coming in and out from there. How do we deal with COVID positive staff and patients, as everybody had to do? And because we're such a tourist town, in and out of the lockdowns, we have a lot of people that own homes in Port Fairy. So that was their residence during that time. So we had quite a few outbreaks that were fun to deal with. And once again, our whole focus was on the nursing home. On the next slide, we, as I said, state versus federal regulations. We were quite happy with some of the state regulations because they gave us some frameworks to work around. But even so, trying to work out how we could fit that into our practice. PPE and RAT tests was the great state and federal divide. Thankfully, because we were so friendly with next door, there were some deliveries over the fence, which were very appreciated, of PPE and RAT tests at times. And now we've got plenty of stuff. Staying ahead of the pandemic, I am very lucky. We have 12 doctors, and I am very lucky that they're all very proactive. So we tended to be first to change in the area, and we often got told that we were too strict, but we were last to revert. So patients have only stopped wearing masks as of about 3 or 4 weeks ago, but the choice is theirs if they come in, and we still find quite a lot wear them when they come in. And staff were the same. And how do we support such a large population of patients, nursing home and hospital staff? So South West Healthcare were great when it came to the first round of vaccinations for our nursing home patients, but then it kind of became between us and Moyen Health. And then we had to take over Moyen Health staff who weren't patients of ours necessarily. And then it became accreditation and storage at branches, because Koroit is such a small branch and Macarthur, they weren't that keen the government to let us have accreditation to store COVID vaccines there. And it was a bit harder when we don't have nurses there all the time to keep an eye on everything. It came down to appropriate number of immunisers versus the number needing to be immunised, how to set up safe and appropriate vaccine clinics. We had drive-through flu vaccine clinics at the start of COVID, and then we ended up working with the hospital and having large, and I'm talking, we would do 500 to 600 vaccinations in a day, clinics, and that was in a very spread out area so that we could do a bit of the safe distancing and whatnot. As I said, we did have some support from Barwon Health for the first round of vaccinations, but then it became our job, and not everyone in our town goes to our clinic, which is fine, but they believed that it was our responsibility to vaccinate them, even if they weren't patients of ours. And then the drive-through clinics and the large clinics were fantastic. Our focus was on the over 65s, but once you put a focus on, everybody wants to be vaccinated. So we had to be quite strict in how we went around what we did. So on the next slide, our considerations for 2023, we, and I'm sure like many of you, are having a lot of RSV. And as a clinic, we actually, during COVID, we were asked by Southwest Healthcare, which is the only place that you can deliver in Southwest Victoria, to take over a shared care program, where women were coming to us because they weren't allowed into the hospital because of restrictions. And so we're now really being very careful still, because we have so many new mums and pregnant women coming in, and RSV has been quite prevalent down here of late. It has whipped through both the two schools in Koroit and Port Fairy a number of times, including one of our staff who was pregnant at the time. So we're kind of just lumping everything together now, because RSV, influenza and COVID are all as important as each other for us. And we've got a lot of COVID complacency. People just don't, it's not a thing anymore. And while we all agree we need to live with it as normal, it is still, and as I say to my staff, it is still the flu. We wouldn't let you come to work if you have the flu. And, our consideration about staff and patient fatigue, staff running out of sick leave, it's just a sniffle, but then that sniffle becomes a bit more. And it's still about us looking after our business and saying, well, hold on, this is what we have to do. So what we, and then ongoing vaccinations, which is huge. There is constant debates about how much stock. We are not giving out many COVID vaccinations at the moment, but we still need them in the clinic. Do we go back to larger vaccination clinics next year? Be great to know what's going to happen. And, is vaccination number 6 the last one, or is it going to be vaccination 9, 10 and 11? Who knows? So on the next slide, we've got our current screening and triage process. As I said, we are first to, first to react and hopefully last to settle down. So all patients are still asked if they have cold and flu symptoms. In our clinic, while I have 12 doctors, I only have 6 rooms, and our nursing staff are actually in a separate building. So if I have to put another doctor over in that building, it's actually in the hospital building. So we have to think about the fact that if we're sending in people that have got cold or flu or COVID, we're sending them into potentially a very vulnerable area. So they are still asked if they have cold and flu symptoms and have they rat tested. If no, come on in, sit in the waiting room, see your doctor, everything's great. If they say yes and they haven't completed a rat test, we are still rat testing. Now it depends which doctor is on call that day. So a lot of the younger ones are actually rat testing before they even speak to them, whereas some of the older doctors will go out and do the test while they're standing there talking to them. But often they'll just ring them in their car, do a bit of a triage. And the way we've kind of got around this now is that we have a back door, they bring them in straight into their room and then see them all under 10 minutes, get them straight out. We wipe down the rooms and then the patient leaves. So do not pass go, do not go to reception, and we'll contact them for billing. Constant reminders to reception that triaging must be completed on every patient. Obviously, that doesn't always happen, but it's just a constant reminder. Patients, as we know, don't always quite tell the truth, and we've had a number of times that we've had people sitting in the waiting room coughing and barking, and we have asked them to, we have some seats out the front, so to sit out there for the period of time. And I mean, we're very lucky. We do have the car park. We do have a front area they can sit in. But in our Koroit area, because the car park is so open, and in Macarthur, the car park is quite a distance away. So we've then tried to find just a separate area that they can sit. So Koroit has got an undercovered area out the front. And Macarthur, they actually have a different room at the front. So we've had to dedicate a room, which then brings all the fun that you have to clean it afterwards and whatnot. So that's what we currently do. The next slide, what did we learn from COVID? We sat down and talked about this the other day, and there were a few positives. So we can change quickly and effectively. And that's been a big one. And often if my staff sit there and say, oh, that's going to be too hard. Oh, no, you did it in COVID. Let's go. Let's do it. Patients don't always need to be face-to-face appointments, but, you know, that's even becoming a fun thing, even to triage those and make sure that the patient does need to be face-to-face, or they can be a telehealth. As I said, we had new collaborations that came out of this stressful time, and it's been fantastic. Me as myself as a midwife and feeding consultant, it's been a massive boost to our pre and postnatal sessions, which has been fantastic and good for the patients as well. Larger organisations may not always be of assistance, but will expect your support. That was something that I think with our smaller hospital next door, we have grown closer to a point, but the tertiary hospital, we don't probably have the relationship we should have, unfortunately, because they were too busy all the time. So changing regulations from the state and federal governments do not make decision-making easy, as all of us or anyone else that had to deal with both will know. We're very lucky. Our communities have really appreciated what we have done for them. And because we communicated effectively and they were able to talk to us, and some of them have expressed their frustrations, and we've said, yep, we absolutely understand. But you also have to realise that if we have someone come in here and all our doctors go down, you've got no one to look after you. Communication. That's pretty self-explanatory. It's not always easy to communicate, and our receptionists, to be honest, they absolutely got pummeled and still do a lot of the time, but we just make sure we look after them and talk to them a lot to make sure that they're giving the right message out to the community, but that the community can feel that they can ring in and talk to us if they need us. Policies and guidelines do make life easier, but again, must be communicated effectively and not be complicated. We have quite a range of doctors who some love a good policy and procedure and some don't. And so just trying to get everybody on the same page at the same time and expressing it in the most easiest way. And a big one, ensure all staff are okay. We still do this. We check in if we have meetings. We make sure that we have a very good pizza joint in Port Fairy. So meetings are often with pizza, and just letting them know that, you know, if things aren't okay, come and talk to us and we'll try and do our best for them. And these last slides, so these are from our latest COVID vaccination. This is quite a special family to us, but this is a family that we thought about a lot. The little girl with the stethoscope often loves to come in and play doctor with us, but she is someone who we love having in the clinic. And so this family were very lovely to let us take their photo at the clinic. And then the next one shows my team, or part of my team, actually. So we tried to make it a bit better. I have a cricket machine, so we all had T-shirts. Some of our children came and were concierge at the clinic, but we were quite, other than that photo, spread out right throughout the clinic, and we're lucky to have a very large area. So we had 6 doctors going on the day, vaccinating, reception and nursing staff. So that was, and it's just, I mean, we had to keep up our own morale as much as keep up the patients, but they loved it. And that's it. Hopefully no questions.
Thank you so much, Caroline. A really interesting presentation there. You know, hearing the challenges and the difficulties being in a rural area. I know you said no questions, but please, if anyone does have any questions, the Q&A function is just at the bottom of your screen there. So please.
Clear, Karen, I've never met you. Don't share slides. 99% conference with everything we said. Frankly, it's just, you know, dealing with the authorities was a disaster, and they crashed our staff along the way.
Yes, we actually had quite a few discussions with Mr. Dan Tehan, is our local member, and we are quite well known to each other, so he knew how we felt quite a few times throughout the process. So yeah, didn't help us in any way, but anyway.
Sounds like there's a lot of shared challenges, but then also probably a lot of shared learnings that I'm sure everyone can really take from both of these presentations. You know, when they're thinking about their, you know, infection control measures, you know, the barriers in place to seeing respiratory patients face to face. We'll give everyone a couple more minutes to put anything into the Q&A function. Look, what sometimes happens is as soon as the meeting ends, then that's when the question pops into your head. So if anyone does have any questions after the session, please feel free to email our education team, and we'd be happy to take those to our 2 presenters at the end of the session and perhaps get a response out to you later. Look, I have already gone through some of those closing pieces of housekeeping, but just a bit of a reminder to everyone that there will be an email going out at the end of the session. This will have the recording link and any useful resources as well. And it doesn't look like any questions. But it seems like we do have some really grateful people for such an interesting presentation this evening. So look, the education team has just put that survey link into the chat. So if you do have a chance, please feel free to complete that there. But it seems we might all get a bit of extra time in our evenings. It's been a bit of a cold and rainy day here in Melbourne. So I hope everyone can stay rugged up inside and enjoy the rest of their evenings. And finally, another huge thank you to Mikesh and Caroline for your presentations today. I'm sure a lot of valuable lessons be taken away from this from everyone that it's attended. So we will leave things there. As I said, thank you everyone for joining our session today. We hope to see you at another one of our education sessions in the near future. Thank you.
Thank you. Bye-bye.
Thank you. Sorry.